First, I send the best wishes of healing to my friend Charles Guinassia. And then I will conclude this morning session of Presbymania with a subject we don't talk about presbyopia. Let's talk about corneal flap ablation as a treatment of recurrent epithelial ingrowth and other post-LASIK complications, severe optical complication. So the first patient the first patient 3 years ago presented with epithelial ingrowth under a thin flap with torn and scars that we thought we could not treat with usual treatment of epithelial ingrowth. So there was a background, scientific background in literature to show us that removal flap had already been performed. So we tried to manage this first patient with the best possible refractive results and to maintain the best possible visual acuity. We were not more in a refractive surgery situation, but now we were in a conservative surgery. So these are few publications who supported the fact we could remove a flap. Post-LASIK complications, as you know, are the flap complication with the flap incomplete, thin flap, torn flap, scarred flap, button hole, small flap, etc. Free flap. We can have post-operative complication with large folds and other untreatable flap irregularities. We can see also corneal degeneration after radial keratotomy or different photoablation. And we also find sometimes flap opacity or central or paracentral after repeated hyperopic treatments or after infectious disease. So this typical case of epithelial ingrowth with major, severe and untreatable astigmatism after some washes. Another case of central degeneration after radial keratotomy and enhancement by LASIK procedure. Another case of hyperopic treatment and repeated hyperopic treatment with a conus with a scare. Infectious case under contact lens. And infectious, spontaneous infectious case after LASIK. Patient who didn't came after the first symptoms. So the most frequent complication is because we use femto is not the flap creation, but is epithelial ingrowth. So the problem with epithelial ingrowth is on one hand peripheral cells which can migrate in the central area, and on the other hand peripheral cells that can stay peripheral but that induce severe astigmatism that you can't operate anymore and that you can't help with glasses and no more contact lenses because of relief irregularity. So we were used to treat epithelial ingrowth as everyone, I think, with scarification, removing epithelial cells and epithelial normal epithelial cells on the wedge of the flap, and using high power and after with a therapeutic lens. But even doing this, we have often a recurrence. So one of the patients with the conus, we did PTK before removing the flap, but we hoped that it would reduce the central opacity, but it reduced it not enough. So what can help us to know that corneal flap ablation is a possible, not so full solution in these complicated cases? Flaps are about 110 microns. If you remove, on this flap you have 60 microns of epithelial cells that will come back. So if you remove this flap, you will remove only 30 for 90 or 50, 60 microns of important tissue. And we know that the flap is not as important for the corneal strength, and it does not count as the residual wall for security. So we do the preoperative check with the pachymetry depth of the lesions. We thought we could have a hyperopic shift because of the central part, the central situation of the corneal tissue we were about to remove. But in fact, we saw that we had a slight myopic shift. So the technique is very, very simple. It's like a normal wash under the laser, under topical anesthesia. You lift the flap, you use alcohol, and the difference is that we end with PTK to flatten the stromal bed, and then it's just a simple scissor cut. And we use contact lens, therapeutic contact lens as bandage, and we have the same side effects than PRK, pain, haze, and pain. So the 10 cases that we put together to show the study. So in the first column you can see the very bad preoperative pre-ablation non-corrected visual acuity, even corrected, often very bad. I would like to say that the most important column is this one, because as I said, we are not trying to give the best non-corrected visual acuity as in a refractive surgery case, but we are trying to rescue the patient. So the most important column is this one, and sometimes it's quite good, sometimes not really, but refractions are not optimized but increased. So the results, the two most important points is cylinder reduction to help to get a better correction from 2.47 to 1.10, and the visual acuity between 20 and 50, we get just a mean 20 and 28. Just like that, as it could be a beneficial side effect, but don't talk like this about it. But we can we realized that we had a good change in asphericity, so we can maybe help to have not so bad vision after the flap removal, because each patient had a better Q factor after the ablation and the healing. It goes together. We have a negative change in spherical aberration. So just photographs of. I've lost all my description, but photographs of treatment after epithelial ingrowth, and cornea don't look so bad. You have early haze, but after you can have a cornea clearer. Another case of epithelial ingrowth. So I had a reflection before and after the talk. So, in conclusion, it's a very uncomfortable position to talk about iatrogenic consequences when you do refractive surgery, but it's a challenging problem, so you have to do something for them. The problem with this technique is the pain, but like the RK, and the transitory haze. Transitory, not always transitory. We don't have any ectatic complication to date because we always keep the security wall that we decided before the first treatment. So we are always above 300 micron. In any case, we have cross-linking ready to do. We get improvement in visual acuity, in visual quality, and we rescue patients, so we can sometimes obtain patient satisfaction. During the follow-up, some patients who ended with 20 on 20 were patients where we perform a PRK consecutively to the flap ablation, and we can sometimes have, it's only 10 cases, but we can hope to optimize post-op refraction. Thank you.
I open the discussion. We don't have too much time, but we have quite 10 to 12 minutes. The first speaker was Espina for presbyopia correcting using the excimer laser Schwinn Amaris.